Meningitis is an acute inflammation of the meningeal tissue surrounding the brain and spinal cord. Those at high risk of getting meningitis are older adults, college students living in dorms, people living in a prison system, and people who are debilitated. There are two types, bacterial and viral. Bacterial meningitis is usually secondary to a viral disease. It's usually caused by strep pneumoniae and Neisseria meningitis. Organisms enter the cerebral spinal fluid through the bloodstream, the upper respiratory tract, or penetrating wounds of the skull. And then an inflammatory response increases the amount of CSF, which then increases intracranial pressure. It's produced red from the CSF to the cranial nerve and other structures. It may extend into the brain during trauma, and if it's not treated, it's almost 100% more fatal. For viral, it's caused by HIV, herpes simplex, enteroviruses, and parvoviruses, caused by direct contact with respiratory systems, and it's different from bacterial because it's usually self-limiting and not fatal.
The subjective clinical manifestations for bacterial meningitis are head and neck pain, photophobia, and nausea. The objective clinical manifestations for bacterial meningitis are fever, increased metabolic rate, vomiting, increased fluid loss, loss of consciousness, diaphoresis, signs of increased intracranial pressure, rash, neutral rigidity, petechiae, coma, and seizures. The subjective clinical manifestations for viral meningitis are headache and photophobia, while the objective clinical manifestations are fever and stiff neck.
The labs for meningitis are obtained from testing cerebrospinal fluid. The pressure will be increased. White blood cell count in bacterial is greater than 1,000 microliters, mainly consisting of neutrophils. In viral, be between 25 and 500 microliters, mainly consisting of lymphocytes. The protein in bacterial is greater than 500 milligrams per deciliter, and in viral between 50 and 500 milligrams per deciliter. The serum glucose in bacterial meningitis will be decreased. In viral, it'll be normal or low. The appearance of meningitis in bacterial is turbid or cloudy, while in viral is clear or cloudy.
When working as a nurse and you come across a patient that has suspected meningitis, you're mainly going to be collaborating with the healthcare provider. As you know, there's two types of meningitis. When it comes to viral meningitis, you're mostly going to be doing supportive care. You can encourage rest, encourage fluids, and administer anti-inflammatories and antipyretics as prescribed. When it comes to bacterial meningitis, it is more powerful, so it's going to require more interventions. We're starting to encourage rest. We're going to start IV fluids as prescribed by the healthcare provider. We also have to keep an eye on the electrolytes and maintain that balance. Also, hypothermia treatment is sometimes used, which is a warm environment, and it is known to decrease intracranial pressure. However, many healthcare providers today believe it causes septic shock and is not as beneficial as it once was. And also, we're going to do an extensive drug therapy. As far as medications go, when a healthcare provider suspects bacterial meningitis, they will order IV antibiotic therapy to be started even before the diagnosis is even confirmed. They start off with a broad spectrum antibiotic, which are underlined on this slide, ampicillin and ceftriaxone to name a few. Once the culture comes back, and if it is a gram-negative bacteria causing the meningitis, then these broad-spectrum antibiotics will be continued. However, if it is a gram-positive bacteria causing the meningitis, then it will be switched to either penicillin or vancomycin. Codeine is also prescribed for headaches, and dexamethasone is also prescribed. So dexamethasone is a corticosteroid, and when it is given along with the antibiotics, it enhances them and it reduces the side effects than when the antibiotics are given alone. The dexamethasone is usually given before or with the first dose of the antibiotics. So what other medications might be ordered for an individual experiencing bacterial meningitis? So as we know, bacterial meningitis is an infection of the brain. This leads to a greater chance of that individual experiencing a seizure due to the increased intracranial pressure. So for that reason, mannitol will be ordered for diuresis to reduce the intracranial pressure. If we can reduce the intracranial pressure in a timely manner, we also will have phenytoin on board, which is an anticonvulsant. Also, as we know, when the body fights any type of infection, there is a risk for elevated temperatures. So acetaminophen or aspirin may also be ordered. These are the medications that you would expect to be ordered by the healthcare provider when an individual is experiencing bacterial meningitis.
Complications of meningitis. The most common complication of meningitis is increased intracranial pressure. This is caused by an increase in CFS production triggered by the inflammation process as well as inflammation itself, which causes ICP because there is a finite amount of space in the rigid skull, and as inflammation expands, there is less and less space for circulation of blood and CSF, thereby increasing intracranial pressure. Another complication is residual neurologic dysfunction. This impacts nerves like the optic nerve, resulting in blindness, the ocular motor nerves, causing ocular movements to be affected, sensory nerves causing a loss in sensory perceptions, and facial nerves resulting in facial paresis. These are all caused by an increase in ICP, which either puts pressure on or irritates these nerves. These complications usually disappear in a few weeks once the inflammation has regressed. A few other complications consist of seizure, bradycardia, hypertensive coma, or death. These are all caused by acute cerebral edema. Complications continued. Non-communicating hydrocephalus is yet another complication of meningitis. It is caused by excretions of cells or purulent fluid that disrupts the flow of CSF from ventricles. If the reabsorption of CSF by the arachnoid villi is obstructed, a shunt may need to be placed surgically. The last complication of meningitis is called Waterhouse-Friderichsen syndrome. This is caused by disseminated intravascular coagulation, adrenal hemorrhage, and circulatory collapse.
These nursing diagnoses pertain to prevention of client complications and disruptions in maintenance of homeostatic balance. Normally, the body maintains a homeostatic level of pressure in the cranium. External and internal stimulus, like standing up quickly or normal alterations in blood pressure, can change this level. The body has mechanisms to keep the pressure in an acceptable range where tissue damage or hypoxia will not occur. Swelling from meningitis can disrupt this mechanism. I included a risk here because this is a pretty serious risk. If a patient's brain tissue is hypoxic, they're going to start decompensating on you really, really quickly. Symptomatic nursing diagnoses relate to what the patient might be feeling or experiencing when they have meningitis. So the confusion is an outward display of what's going on with the brain tissue, be it hypoxia or pressure from the swelling in the cranium. And at this point in the nursing curriculum, we've talked ad nauseum about how we always need to control pain in every single patient that we have.